Uh, we're going to talk today specifically about the basics of fall prevention. And in that, we're going to talk a little bit about why fall prevention is important, the impact of falls on everyday life, some risk and protective factors, and key takeaways. Throughout this, I'd like everyone to be thinking about how this presentation would go in a community because we give this type of presentation in the community. We give this type of presentation to professionals. The differences are how it is that we bring in some of the examples. I'm also going to weave in some brain health and dementia related topics as I chat. And there is absolutely a reason for that. We are looking for the easiest entry point to talk to people about tough topics. And fall prevention is well studied, lots of evidence-based, data-driven interventions, and people understand that they are going to fall. Not everything about why they fall, but that they're going to fall. And so we can broach a lot of tougher topics by bringing this one in. Also, a surprise guest lecturer today is Hermione the cat. She will absolutely be all over the place, and I apologize in advance for that. So let's dive into this, shall we? So first of all, why is fall prevention important? Well, the data tells us it's important, right? According to CDC, falls are the leading cause of unintentional injury worldwide. We are looking at 38,000 deaths in 2021. And an injury, a leading cause of injury death, not the leading cause of all deaths, but the leading cause of injury death. You certainly see spikes among our younger generation, 0 to 4, and you see additional spikes in folks over the age of 65. And we're going to get into those reasons momentarily. In Georgia in 2023, fall-related death was the third leading cause of injury deaths here in Georgia. And we're going to talk a bit more about that as well, if my slides will go forward. All right, so overall rate in the United States is 11.1 per 100,000. Number of deaths, almost 220,000. For every person that died, you are looking at 32 people hospitalized and 138 people treated and released from the ED. The reason why this particular data is important is because we're looking at the problem and the resources required to address the problem. And so every time we have a person die from a fall, we're looking at 32 more that are in the hospital. They may need post-hospitalization care. They're also more likely to fall. Once you've fallen, you're 2 to 3 times more likely to fall again. And so we really have to look at rehospitalizations, those costs associated, and not just the dollars, but also quality of life type of issues. So all of this data really contributes to a broader picture of what's happening in terms of the burden of falls for any individual and their families. So we look again at data. This is small, and I apologize. So just take a moment to orient yourself. When we look at the top 5 leading causes of non-fatal emergency department visits in 2023, unintentional falls, again, across the top, you see from less than 1 all the way to 65 plus. We are looking at falls for every single age except for 15 to 24. That's unintentional struck by or against. And you'll actually see in that teen to young adult age range, the number 2 cause for an ED visit is an unintentional fall. So when we look at the data and how we code it, those two could possibly be interchangeable depending on what the data tells you. This is really important for how we do programming. And so I really love getting into the data, but that is a discussion for another time. And I know that our other speaker today, Kay, will go into some of the hows and whys of all of this. So what we really want to do is we want folks to understand that falls are not an inevitable part of aging. Falls are absolutely preventable. And because of their preventability, well, and in addition to their preventability, we can predict it. So we want folks to speak up. We want them to do some basic checks of themselves and their environment, hence checking your eyes, making your home safer, and keeping yourself moving. Because falls can happen at any age, They really are not only a threat to our health, but a threat to our lifespan. They really do change the pattern of quality of life over time, depending on what's going on and how severe the fall is. So, where we can prevent these, where we can predict them and then prevent them, it's really important to do so. So, let's dial into what are those risk factors for falling. Everything you see on here in this visualization can create a risk for a fall, can create a fall. Foot problems, dizziness, history of falls, medications. Sometimes your medications can cause dizziness. Your history of falls can cause you to not want to participate in normal activities, which means you're then going to have difficulty with walking and balance. These are presented in a circular fashion for a reason, as they tend to build upon one another and just keep you in this sort of cycle of being at a greater risk for having a fall. So when we think about risk factors, we are thinking about specifically the characteristics that increase the likelihood of a negative outcome. So what is going to keep you from participating in really important activities of daily living? Things like difficulty with walking and balance. Nobody wants to fall. And so we tend to maybe not do things that we enjoy if we're worried about falling. If we have vision problems, if we have medications with side effects, and each of these things compound upon one another. So it becomes pretty important that we also look at what's protecting us from having an increased risk of a fall. So, what is it, what characteristics, what environmental things or behavior things can we do to help protect and reduce our risk of having a fall? And those are things that we do ourselves, like physical activity and home modifications and medication management, to getting things like help with what's the totality of the burden of all of our medications on our body. We get help with that from our doctors. We get help from doctors and other professionals with our general health. And then environmental things like picking up the rugs and making sure that we're wearing proper footwear for sort of behavior type of intervention. The shoes are cute. They may not help your risk of a fall at all. And so we talk about that in our community so that folks have a better understanding of some pretty common sense things, but things that are so ingrained that we may not automatically think of them. There are several types of risks that we've really got to pay attention to, and each of these independently and together increase a person's chance of falling. So, physical risks, what changes are happening to your body, whether it's aging or an injury or a chronic disease, maybe a traumatic brain injury. What are the things that increase your risk for a fall? Interesting statistic when we look at folks with dementia in hospitals, 86% of them have had a traumatic brain injury. And I'm sorry, yes, 86% of them have had a traumatic brain injury related to a fall. And so there's a real opportunity for prevention there when they've had a fall to reduce risk of TBI. And when you've had a TBI, you're at risk for developing dementia. So you can maybe have a modifiable risk factor there. And we have to look at that kind of step ladder of worse outcomes over time and help people draw back from that. So that leads us from the physical risk factors into behavioral risk factors, things that we do or don't do to increase our fall risk. So, how can we make sure that we're not stepping up onto a chair with wheels or trying to get something off of the top shelf or even a rickety chair that is in need of repair? Making sure that in our home we've got a proper 2 or 3 step ladder and something sturdy to hold on to, and preferably a person there to help us kind of keep an eye on us as we're doing those things. So those types of behavioral changes really make it so that we are reducing our risk of a fall. And then, of course, environmental risk factors, anything in our home or community. So in our home, rugs, not having handrails on stairs. In our community, no sidewalks, uneven sidewalks, those types of things that might be modifiable so that we can reduce that risk. one of the things that we want to do with all folks is promote the ability to take action on your own. Certainly, we can ask folks to talk to their doctors, and we want to do that. But there is some stigma around talking with your doctor. And when we look generally generationally at people, our folks of the silent generation and maybe a generation after that, they are less likely to speak with a doctor about their risk. And so, where we can have tools like a falls free checkup, which is a product of the National Council on Aging, you can actually scan this QR code right now on your phone if you want, and it will take you to just a few questions online. They don't save your information, but what they do is they ask you the questions and then they email you your results and talk to you about what your risk is. And you can take those results and talk to your primary care provider about it. So it leaves it up to the individual and gives them a way to be proactive and then to advocate for themselves in a very concrete way. And that's what we want to do. We want concrete, specific solutions where it's possible. We have to think about mobility overall as we age. This isn't just for folks over the age of 65, anybody that's middle-aged, anybody that has a medical condition that makes them more frail. We've got to plan for potential changes in mobility over time and in case of an injury or disease process. So some of the things that we can easily do that is working on visual, physical, and cognitive changes that affect our ability to be mobile and out in our communities. So we know visual acuity can mess with our ability to see properly and assess our environmental risk factors. We know that having assistive devices is helpful and it is a strength. However, when we don't have the proper assistive devices, it really affects our balance and our ability to get around in a safe manner. Also, we want to pay attention to things like memory loss, confusion, differences in speech, changes that are affecting our ability to connect with others, or changes that we observe in others where they don't connect with us in the same way. Those can be because of medication. It could be because of something like dementia, but it could also be because they have sustained a fall and a traumatic brain injury and they're not connecting those two pieces. So, when in doubt, a self-assessment of our own mobility is really important. To address some of that, CDC has a really great tool. It's called the CDC My Mobility Plan, and it really takes an ecological approach, which we love in public health, looking at yourself on how to stay independent, looking at your home on how to stay safe there, and looking at your neighborhood, that community aspect, staying mobile in your community. So the My Mobility Plan talks to you about each of these areas and how to be safe and be healthy and be mobile in each of these scenarios, actually helping you to write things out so that you can see it in front of you in a plan format. Right here on the screen in front of you is another QR code to that effect so that you can take advantage of that and perhaps even share it with friends and family in your communities. Another really important resource to consider are strength and balance exercises. Again, we've got a plethora of strength and balance exercises that are evidence-based, that are data-driven in the falls prevention world. Matter of Balance addresses your fear of falling, but also includes exercise, which addresses those strength issues we saw earlier in terms of risk factors. Tai Chi is evidence-based and can reduce your risk of falls by 30 or more percent when done properly. Bingo size, wildly popular, so great in terms of helping to educate a person and bring awareness up, while also playing a game of bingo and incorporating exercises while you're playing bingo, things that can be done in or at your seat. So a really creative and innovative way that's getting more and more evidence behind it, showing the positive impact on decreasing your chances of falling. Otago is for folks that are the most frail in the community, but still generally in the community. The beauty of this is that it is PT led, physical therapist led, and not only can physical therapists bill for this, but also it's really a nice way to start with physical therapy as needed and then almost graduate into any one of the three prior interventions I just mentioned, so that you've got this continuum of care and continuing to reduce your risk and continuing to be healthy. Silver Sneakers is a long-standing program, exercise, health education, group socialization as well. Really, really strong program that has great evidence behind it. On the right, you see another QR code about being able to register for these programs. What we always want to do is we want to make folks aware of what's available in their areas. And Kay will talk more about that in her presentation, understanding the resources around you. But area agencies on aging, frankly, should be mentioned in every presentation you do, no matter what the topic is. Disease, injury, risk, protective factors, talking to professionals, bringing new partners on board, speaking and engaging with the community. We should be talking about our area agencies on aging all the time. Brain health. So we have to think about brain health when we're thinking about fall protection and fall prevention, excuse me, because our brains help us process. Our brains protect us when we're able to use them properly and think with them. But a lot of different health conditions, not just falls, certainly in banging or hitting your head and having that TBI moment, but a lot of things can change the way it is that our brain functions, including chronic conditions. So if we're managing our risk for a fall by being more active is actually healthier for our brain, healthier for our heart, healthier for managing chronic conditions. And so when we have an individual that might be hesitant or resistant to participating in exercise programs or things that reduce their risk for a fall for a variety of reasons, um, voicing that sort of cost benefit, if you will. Um, they might be doing an exercise program, but they're actually in doing that exercise program, helping their risk of a fall, improving their chronic conditions, protecting their heart, protecting their brain. So they're really getting a lot of bang for their buck, if you will, by simply participating in the thing that's going to immediately reduce the risk of a fall. People really sort of see that as a time value benefit for time that we have less and less of, and that we have to prioritize more carefully. And so that's one of the things we try to think of when we're working on our fall prevention programs. Specifically looking at reducing the risk of dementia and Alzheimer's disease. As I said, all of these ways that you see on the screen are ways to reduce your risk. It's not just about memory loss. That's certainly the most common thing that's discussed and known. But this is such a stigmatized topic. I would dare say that dementia and Alzheimer's disease are just as stigmatized, maybe a little differently, but just as stigmatized as, say, cancer. The big C word. Folks don't want to talk about this. It's very scary. It's hopeless because in the case of dementia and Alzheimer's disease, there's by and large no cure for it. And I say that because occasionally medications can create an issue to where you have medication-induced dementia. Kind of rarish, but by and large, there's no cure for any of these things. So they become a sort of hopeless thing that you just have to deal with. But the reality is that we can reduce our risk pretty significantly by addressing our cardiovascular health, having a good sleep hygiene, working on our mental health or socialization. Again, when you think to the very beginning of our talk today and thinking about that sort of circle of physical risk factors, you can put all of these other risk reduction things for dementia on that same circle because addressing these helps to address those physical risk factors, helps to address your risk of a fall, keeps you stronger overall. And that's really what it is that we're trying to do with all things. Brain injury, wholly separate from dementia, very, very important to brain health, because a brain injury can impact your personality, movement, and vision, and because it is sometimes subtle. Only one personal story in all of this. My daughter at her end of her junior year of high school, Easter Sunday, was sitting in a chair at her grandparents' house, threw back her head and laughed and hit the back corner of her head on a corner of a wall. Grade 2 concussion from that. She missed the rest of the school year and went back in the beginning of her senior year after a summer off and feeling better. And actually, we had to modify her school schedule the first part of that year because she still had a concussion and was still under concussion protocol. Took her about 9 months to really feel as though she was healing from that concussion, had never had a concussion before. But when we have dizziness, when we have trouble concentrating and headaches, it might not just be allergies. It might not just be, other things. So having those conversations with our doctors, really dialing in and paying attention to it is really important because those brain injuries absolutely impact everything else it is that we do. So doing things like wearing a helmet, wearing a seatbelt, having regular checkups with your primary care physician to understand your baseline of your brain health really, really helps if you were to have a brain injury. And those are the things that we want to talk to people about in small doses. Vision changes. Um, Having impaired vision doubles your risk of a fall. Getting a regular annual eye exam absolutely reduces your risk of irreversible vision loss or injury from a fall. Getting updated prescriptions are incredibly important. And we happen to have a lot of docs available that can help with vision. So we want to make sure we're working on that. Managing our medication is also very important because our medications can impact our brain, can impact our sleep, can create other side effects that lead to a fall. We want to know what's going to happen with a medication and really be proactive and ask questions. Pharmacists are such an incredible resource. And we want to make sure that when we have medications to treat our regular chronic conditions, maybe we take an over-the-counter vitamin because it was recommended. We really want to know how those things interact so that we can keep ourselves healthy and let the medicine do what it's supposed to do, rather than what it might do if we aren't paying attention. 6 really great tips to prevent falls at home. Again, I've said this several times talking with your healthcare about medication side effects, doing strength and training and balance exercises, getting your vision and your hearing checked, paying attention to how you can make your home safer. That's putting a nightlight by your bed and making sure you have a clear path and a lit path to the bathroom, which is where a lot of falls happen. They happen in your bathroom and they happen on that path to the bathroom. So, using assistive devices like canes, and quite frankly, teaching people to do something as simple as going from laying down in your bed to sitting up in your bed, waiting a second, breathing, then twisting to put your feet over the side of the bed, taking a second and breathing, then standing up and giving yourself just a second to acclimate to the world around you. And that's one thing to do when you know you're getting up in the middle of the night or any time to go to the bathroom. It's another thing if you're in sort of an emergency getting to the bathroom situation. And again, that's where you kind of see this first part of these 6 tips, and you go back and you talk with your healthcare provider about why are you getting up in the middle of the night? Is there something you can do to reduce getting up in the middle of the night? Can we shorten the trips to the bathroom? There's so many incremental things that we can do But these tips are designed to get people to ask questions and talk about their individual situations. And that's really where the magic kind of happens for us as professionals. We can come in there and start introducing additional resources, quite frankly, for each of these 6 tips that can further help an individual or help a community when we're noticing a particular problem there. Occupational therapy and physical therapy, which is not actually mentioned on here, but occupational therapy, everything in fall prevention is a team sport. Our occupational therapists are incredible resources. Our physical therapists are incredible resources. Physical therapy helps you physically. Occupational therapy helps you in your environment, in the environments where you live, work, and play. And helping assess a person's abilities. Super, super important to get somebody on the same page about where their abilities are, where their needs are, and then to move them forward with what they need, whether that's some exercise things or a cane or a walker. Those things and the stigma around some of those interventions really have to be addressed so that folks can really get a benefit. But I cannot say enough about our occupational therapists, professionals, and our physical therapist professionals. They really do make a big difference and should be at every table when we are talking about fall prevention with our communities. So I've got some key takeaways for you, and I'm happy to answer any questions or talk through any scenarios. But there are so many tools that we can add to our individual toolboxes, both as professionals and as individuals in the community, to help us prevent a fall. The National Council on Aging Falls Free Checkup, super easy, doesn't save or share information. CDC My Mobility Plan, Georgia Health Matters, and your area agencies on aging for local fall prevention exercise programs. And if you're worried about engaging in those, sometimes folks don't think that they're not ready for those, or those are for other people. Go to the Y. Go your local churches more and more have you can bring programs to where you are and where you live, work, and play, and that's what we want to try to do. And our area agencies on aging can help with that. Most importantly, reducing stigma around fall prevention, because fall prevention is quite frankly a window into dementia, brain health, safer driving for all ages, but particularly older adults, all sorts of chronic disease management, all sorts of other topics that people don't think about and are a little bit afraid to talk about. That's where we want to bring fall prevention in and addressing risk of falls because it opens the door to talk about everything else. And people really see a value for talking about multiple things, even though it might be over time rather than all at once. Here's a listing of available resources and associated links. All of these links work, addressing everything from driver safety and fall risk and concussion and local exercise programs that are available to everybody here. We always make sure that we share these with folks so that they can access themselves and do some proactive things on their own. Really appreciate your time today. I'm always available for questions here at the Department of Public Health's Injury Prevention Program. Megan Passano heads up a lot of our fall prevention work and the day-to-day activities, and she is an amazing resource and a great partner. So I'll stop sharing and happy to take any questions or comments that folks have.
Hey Liz, amazing presentation as always. I learn so very much from you every single time you give this talk. I know you mentioned pharmacies, and I just had a quick question around them. How have you seen pharmacies engage with fall prevention activities, like when you're hosting events or when you're doing things out in the field? Aside from kind of giving advice, how do you see the pharmacies kind of working in this space?
Yeah, absolutely. So, pharmacies are great for medication reconciliation. because most people use one pharmacy for most of their medications. And so you can absolutely, bring your medications to a pharmacist with an appointment. You can also bring them to your primary care physician, frankly, and shouldn't be afraid to do that. But pharmacists are great advocates for the folks for which they are filling prescriptions. If you have a concern, particularly around interactions of things that people are taking that they consider as natural, St. John's wort, for example, you should absolutely be talking to your pharmacist about how prescriptions you have might interact with that or other natural supplements. And so they are amazing and frankly love to answer questions that people have about potential medical interactions between different types of medication. Kay, I didn't know if you had anything you wanted to add to that. I know you work in this space as well.
The pharmacies, I think that has been a challenge. Liz, for a while, you had that connection to
And
a chain for a while, and that was really helpful because at the local levels, then we could tap into that, and you'd already made that ask. I try to find the pharmacies nearest to where I'm hosting my events and I'll start with one, and if I don't get a response, and then I'll go to others. In the last 2 years, I've been this close, and the person's committed, and then at the very end, the schedule changed, and they couldn't come, and so I had the person committed to come, and I think they really are valuable. A lot of times, it's not the time in the larger events maybe to have a full med review, but they can ask a specific question, talk about those ones that are related to falls. We usually use the CDC handouts that there's one for providers that talks about the being aware of the different types of meds that are more associated with risk. And then there's one that's for the community members. And so a lot of times in my training to others, I'll give the provider one to the volunteers, and then I'll give the other one and have the pharmacy rep use that as their talking points. So we have done it that way, but it is tough. I find the local ones easier, but then they have less staff. And so what's been happening is somebody's out or whatever, and then they can't do it because they've got to work the pharmacy.
yeah, it's one of the tougher partners to bring to the table. Um, you can have some luck with pharmacy students, like you might have with physical or occupational therapy students, but you do need and want to be specific in what it is that you're asking of them.
Good point.
That's really helpful. Um, I had one more question on a different topic, and that's did you have any guidance on how to approach the conversations, especially where it might feel a little stigmatizing to the person? Any techniques that you would kind of advise for guidance on how you start approaching maybe the Alzheimer's or dementia conversation with someone to kind of to to not be stigmatizing or to not create that impression?
Yeah, so generally you let, particularly if you're in a community, right? We're going to bring a plethora of things, sort of this a la carte menu, if you will, of topics that we're talking about, just like I did today. And then you ask them what they want to know about. And if they see the words, they will ask the questions. Um, rather than coming in and giving all the answers sometimes it's better to just teach about the topic of having a healthy brain, which is a little bit nuanced and it's certainly less uncomfortable. It's not as uncomfortable, but they don't automatically make that connection to dementia. And so meeting them where they are, talking about how a fall, if you hit your head, could hurt your brain. And then letting the idea be theirs to talk about dementia. We're not talking about a one touch and done situation. You're talking about being in a community more than once. Folks will come to you. The other thing to do is talk about if you are are providing care or have been a caregiver for somebody with dementia or have seen dementia in your family. Not talking about the individual, but what they're seeing in their sort of locus of control, right? You're going to find them there. That's where you find them. And then finding out what their experiences are and how they've navigated that as a caregiver or a neighbor or a friend or a family member. And then start talking about, what questions they have and what their experiences were. When we employ sort of things of adult learning, those series of adult learning in there, and those small groups, they're going to talk about everything. They're so hungry for knowledge. They're so hungry for the what to do about something in concrete ways. It that really does help lessen the stigma of it.
I think though the power of the group too, Liz, that you mentioned, don't I
Yeah.
think that the discussion is often more important and uncovering it and talking and sharing about the struggle with people that they perceive like them is more important, whether it's falls or dementia or chronic disease self-management, is more important than the content that you present because you can create a connection and open a door through those conversations. And most people don't actually remember the content that you present at things like this. If you go back and ask them, they don't actually remember. So
Right.
that it's more that open engagement, the two-way learning, having that attitude and providing times for that I think is critically important, no matter what you're talking about.
Well said.
Thank you. Are other additional questions? Hearing none, or if you guys just want to sit and think about Liz's presentation for a little while, I will turn it over to Kay, and then obviously there will be time for questions again a little later.
All right. Hi, everybody. Officially, my name is Kate Graham, and I teach at Brenau University. Thanks for the occupational therapy plug, Liz. I appreciate that. I didn't pay her, I promise. Um, and we're going to talk a little bit about sort of from practical experiences, and then I have intentionally stopped in places where I really, and I don't care if we get to the end because I want us to be more engaged in the conversation. So I checked with Jill to make sure that was okay in terms of just the whole process and hearing from one another. And I love this idea of the echo learning, that it's the two-way learning, and that's one of the reasons I love working in the community and working with others in partnerships like the coalition that I'm going to talk to you about, because I learn all the time and it enhances everything that I do. So this is finding partners using the data and mitigating risk without specifics, but more from a case sort of scenario. And so we're going to focus. There'll be three sections. One will be just talking to you a little bit about what we do at the coalition in Northeast Georgia and how we've gathered partners, and we'll have a discussion about that, about how we use data to help direct what we do, and then how we choose and decide those risk factors that Liz did such a great job talking about, or the protective factors, and what we're emphasizing in the communications. So the little bit about the coalition, I see some folks on here that I know. So this Northeast Georgia Fall Prevention Coalition started because of Liz and her work with a state fall prevention coalition that I was active in, and she was doing these great big events at Shepherd, and so we decided we would try to do an event like that in Gainesville area. And I teach in occupational therapy at Brenau, but I'm also one of the co-leaders of the coalition that came out of our first effort of the event. And we had such great success and so many partners and volunteers and students involved. And we had more people than we had to add sessions at the end. And I mean, it was just a huge success. And so those of us that had come together initially were Legacy Link, so an area agency on aging, both the community section of the hospital as well as the rehab section of the hospital, both inpatient and outpatient, Hall County Fire EMS, and then we had students from nursing, PT, and OT, I think, and then faculty support. That was like the core group that we set this up with no money, and just basically went out there and did it. And then we decided, hey, we want to continue this partnership. And so a coalition is just a loose way to, an informal way to work towards common good on a common topic. And we decided that we would meet monthly. At the time, we met in person, and then during COVID, we shifted in person and then online. And then during COVID, we shifted to online, and we've continued to meet online monthly. We serve the same area as Legacy Link, which is the area agency on aging. The hospital serves roughly the same area, and that makes it helpful so that when you're trying to do your events, that it's in their area. All your partners are in their area. We were just having conversations yesterday where somebody's on from sort of outside the area, the main area served by our hospital and Legacy Link. And so just makes it easier when we're all in a geographic space. In terms of our members, I ask volunteers when they volunteer at an event for us, I ask them, do you want to continue to receive information from us and our communications and notice of monthly meetings and whatnot. And currently we have about 25 to 30, I didn't count, but it's somewhere around there, people that are receiving that. And then we have like a core group of about 6 to 8 that when it works in their schedule, they're definitely there every month. And I put some of those folks on there. So we have Legacy Link, the area agency aging reps. We also have reps from the hospital system, Northeast Georgia Health System, trauma nurse educators. They are such great people to partner with because they have to do this. They have to work around falls, and they have to work and they have to do community events, and they have access to data. And it's just a really easy person to work with. And then also we have an outpatient PT on the regular on the big mail list. We have inpatient therapists as well, OTs and PTs, but we have one really committed PT. She even comes on her days off. We have a county library representative, much like I saw Tom was on here before, much like Tom, that he comes all the time, and he came initially out of personal interest. And we have used libraries often for our spaces to host smaller events. They're a great way to reach the local communities. We have both PT and OT faculty that serve on the core group. And then the community members fluctuate. Right now we have one instructor that is a Tai Chi instructor that is currently coming to the monthly meetings. So some of the activities, Jill asked me to talk about a little bit about some of the things that we've done recently. So we have both large and small events. Typically what we try to do in a year is in like December into January, we try to figure out what we're going to do, set some objectives, and usually it's maybe one big event and then one small event. The small events often, like I mentioned, we use libraries, do a little sort of mini screening. Maybe there's 3 or 4 of us there, and there's 8 people that sign up at the library. Or it could be just an education event at an assisted living or at a affordable housing. There are also great connection points because they need to do education for their residents. So they're happy to sort of, if you need to want to get the word out about something. The large type events are like what we call spark events. We don't charge for vendors, and the vendors aren't there except to provide like screening and service and education. And typically we have anything from blood pressure checks with the diabetes team from the hospital, if we can get them, to the fire services, to PT students doing screenings, to OT students talking about home evals, to or home safety, to the Tai Chi instructors doing a demonstration, we usually have OT, but somebody suggested we could maybe get an optometrist, which we haven't tried before, to do vision screenings, because as Liz mentioned, that's a big deal. So we do a lot of, and usually have a gym area. Like I mentioned, we never have any funds. If we do, we have just a little bit of funds. So we get people to donate, and we go with what we have. So this last year, we didn't have donations for food. We had a little money left over that we used like for coffee and snacks, but we didn't provide lunch. Lunch is a big draw. People come for that sometimes if you have the money to provide it. So yeah, we've done all these things. And the nice thing is sometimes we do it all the way as a coalition and we have like multiple representatives, and sometimes they're just one organization, let's say the hospital, but we've had conversations in the background that sort of help set them up for success. And I wanted to share a little bit about what happened yesterday. We had our coalition meeting. We meet once a month, like I said. And I was trying to finalize what the objectives were for the year, the goals for the year. And the conversation was so rich, we ran out of time, which is a lovely thing to happen. And in yesterday's meeting, the trauma nurse educator was sharing about 2 programs she's developing and asking for feedback. So one of the things that we do is then, might put that I've used them for my the feedback for something that I'm maybe doing for research with my students, education. If somebody's putting something together in terms of education, for getting people's feedback, because you've got all these experts right there that can give you feedback. And then also we were talking about, because we have this new person that's joined that's a Tai Chi instructor, and she was saying she had availability 1 day a week, that she's looking for a place to do a class. And then that generated a whole nother thing about other people who might be able to help network with her to get that out there, and that class opening filled. So that's the kind of thing that happens in our coalitions meetings. And what we kind of do, we try not to put too much on our plate. So as the coalition, like I said, we may do 1 small event or 2 small events. And if they pop up, they're not a big deal to do. And then maybe 1 large event a year, so that we don't burn everybody out. So I mentioned this section's on partners. So finding your people is so critical. And just like falls is a multi-issue problem, they call it like a multifactorial problem. So we need to come at it from multiple contexts. So Liz, I love that my mobility, I was just teaching my students about that this week in class. And it's a great way to sort of access multiple points in there, as she mentioned, sort of an ecological perspective, and then also the multidisciplinary perspectives as well. And gathering those other people outside of whatever you're doing and who you are. If you're a nurse, or if in my case, if I'm an OT or whatever, who else can I find and create these connection points? Because a lot of times, especially in the hospital system, it's fee for service and medical. And Legacy Link, the area agencies on aging, operate completely differently. They're state and federal funded and grant funded and community based. And so they're to bring those together are often a hard sell, a hard thing to do, and we need to be intentional about it. I've listed here some people that you might look into. Some are easier than others to get access to, or to get somebody to response. You could, the pharmacy was another good one that came up. I like the idea about trying to tap the pharmacy students. If you have a pharmacy department near you, that might be an easier ask. And if you can find local providers. So when we do our local events, And I'll get into how we choose those later, but we look for local partners. And I have a dual kind of, I mean, yes, I want to serve the older adult community, but I also want to educate the providers that are out there about what exists and how to work together effectively to address falls. And so I do education and hand them information, send them information. A lot of it's based on the steady toolkit to help that. So seeking out those contexts locally, wherever you're going to do your program, is also really helpful. And then in who you're choosing in your partners, what's the interest, what's the needs, and try to find folks that'll help serve something you're doing so that it's not at cross purposes to what that you're doing. I mean, they're not going to overlap exactly, but you're seeking sort of that sweet spot with what you have and what you think is needed and the resources, all of that kind of intersecting together. That's where it works well. So time for y'all to talk and me to stop. So if y'all want to just leave your microphones on, and we can just go through some of these questions. So one is, has anybody worked with partners that I didn't mention or found somebody particularly effective? So does anybody have experiences that they want to share around partners?
I know, like for me, I'm just partnering with our North Gwinnett Co-op area. They of course take care of like the low income, the low needs, but they have a big senior population. So they have like a buddy program kind of thing, which I just have joined and been partners. So basically, you get like some senior adults that you check on and stuff that you help educate. So they have a big population of senior adults, which I've been trying to. So I'm trying to partner with them, see what other needs I can do as far as like teaching about fall prevention and medications and all that.
Yeah, that's a good point. At the end, making where the sweet spot is in terms of what do they need and what do you have to offer and how can you kind of morph into that to bring them to the table with you, right? So that's a good.
Correct. Yes, ma'am.
Other thoughts?
I know you pointed out public libraries and Tom Brooks is on the call, but that has been such an amazing partner for my team. They are such a trusted source in the community. So if you're having a difficult time getting into a specific community, your public libraries are a great starting point. And we've had such great feedback and continued partnership with public libraries.
And as an access point, it's not medical. It's not religious based, which might be putting off for some people. So it's a neutral space and they're everywhere and close. So it is, and they typically have at least one room. Now, a lot of times they're small, so you have to kind of go and see what you're working with. So you make sure that you create something that works in that space. But it can be really helpful. And they have a group of people that regularly come to them and use their services that you could recruit from in terms of your your participants, because they'll be there and that's who's likely to come. It is very hard actually to get the word out. You would think with social media it's easier, but it's so many competing things now. I think it's become harder, that people aren't looking at a newspaper, whereas you could put it in there before, or maybe it's a flyer, but it seems more difficult in a weird way.
Yeah, I agree with that, Kay. We've had some luck with extension offices. So there's an extension office in every county. And certainly their messages are for farmers, for folks doing agricultural type things, but they are a community-wide, county-wide resource. And so where you can get in and talk with them, they're always willing, even if they have a limited capacity, if they can find a way to do it that doesn't overburden their limited capacity.
And to that end, your partners are sometimes partner for an event versus partner for the long term, right? So also be thinking about the ask and what you want somebody to do, and or would what you're seeking in that partnership. That in the case of the extension agency, maybe it's somebody that once a year they help you access that area in terms of doing an event or something. Other thoughts? One of the questions that Jill really wanted to think about was kind of how do we bring new partners in, and then sort of before that is if you've what experiences have you the difficulties. So like we've mentioned pharmacy and EMS, like when I have them, they're great, but often it depends on who's in charge, and then they leave, and then you have to start all over in those processes. And build those connections and start small with one event, and then maybe you can seek other events in terms of that. So I didn't know if other people had suggestions on how do we seek these folks that might be outside of our discipline, outside of our little working area, that so we can be more effective in fall prevention. I think one thing I know in terms of recruiting new, sometimes something like the coalition, so like our coalition or the state's coalition, it because it's somebody else knows somebody. You know what I mean? Like Liz knew, I reached out to Liz one time when I was trying to get a pharmacy rep, and oh yeah, I do have somebody. So like the more connections that you have, the and that you work on getting, that the easier it is, it might be to help recruit those partners, because they might know somebody and they could do that introduction that might be received differently. That is how we actually got the current fire connections that I have. Is the trauma nurse educator was knew them from a meeting that they all attend together, and got me that a specific person's contact who has been great about getting back to me and answering questions and showing up at the big event and whatnot. So it can be critically helpful. Other thoughts? All right, we'll go on. Something to think about though, that you don't want the more diverse you are, it's harder sometimes to wrangle things because people have competing interests, but it sure is enriching in terms of what you can do, for sure. All right, so this now kind of moving on. So that was partners, and then data. So Liz mentioned some, and I know that we have coming in future presentations more specific guidance on how to access, like Liz had the all those statistics for us that she had pulled from sites. And it is important to have something, not just to decide, like I tell my students all the time, don't just decide you think it's best. What's guiding that? And so we've used data to prioritize locations for our events. So for example, the hospitals will pull county level data to see in terms of their highest admissions, and then also in terms of admission to the hospital, but even more specifically through the ED, through the emergency department. And so that can be really helpful, because then if that's an area with the highest falls, then you can start to dig deeper and go, okay, what do they have? Are they, are they partnered with Legacy Link, and do they have fall prevention programming, and do they have, so we've done that a couple times in terms of sometimes they still have all of those things, but we've still used that to sort of prioritize both large and small events. And that hospital data is really can be really, really helpful. And it's helpful for the trauma nurse educator folks too, because they have to say when it's their highest reasons for admission, part of the trauma um, um, criterias are they have to show that they're addressing it. So it's a win-win in terms of that. Sorry, I see a spelling thing. But so choosing locations for there. In terms of, and I've mentioned this, it's sort of seeing, okay, where is Legacy Link or the trauma nurse educators offering the current services, and where's like some desert areas, and then can we do something there? Is it we targeted training so people can do their own? So the area agencies on aging, like ours, she's one of the trainers for Matter of Balance, so she trains instructors. So maybe she can target those areas to do that. Now she's doing that as part of her work with Legacy Link, but we can kind of claim that as part of the coalition and understand it or help facilitate it, show up to be the healthcare provider, teaching in the Matter of Balance, for example, to help. Or in those sort of desert areas, if we've done a community event like she was just sharing this week, that one of the events that we did that was in a more underserved area, she's doing now a Matter of Balance. They wanted, one of the things that came out of that is they wanted a class there, a Matter of Balance class, and she's using the healthcare provider that we tapped into for the event, and trying to keep them connected to the same time is also really helpful, rather than a one and done, but like, trot them back out again and ask if they would do something else for you, like be the healthcare provider or something, so that you can maintain that connection, even if it's a distanced connection. And then just to be transparent, we certainly still have issues with like low utilization, to Liz's point, and not everybody wants to hear about this. And even though it's a big issue, is there a separate route in? Is there another route in? Is there you pair it alongside with? And then also just looking at, we had for the first time ever this fall, we had our large event, and we did it actually in Gainesville. And it was at the Y, and it was on the edge of Gainesville. And one of the things in breaking down what happened, which was a low participation for participants, we had like 55 volunteers, but our participants were really low, and we didn't really pull in the senior centers from across the region strongly, just the local one. And there just wasn't a lot of buy-in, and the folks at Legacy Link who did the registration for us, they said, well, that they had a couple people say that it was too far away. So even though it was in Gainesville and on the edge of Gainesville, the perception was, and if they got on the 985, it wouldn't, it wasn't far, but in their perception, it was far. So like, thinking about that, that's where those library kind of things they're close. And the perception, it was too far, even though I didn't think it was too far, but it doesn't matter what I think. We got to start where people are. So we had that, and we looked at trying to figure out kind of what happened. We advertise the same way we normally do and everything. So that was an interesting conundrum, which this year we're going to go into an underserved area in the mountains for our large event. Usually we get those, I have to use churches because there's not as many bigger facility areas there. But, we did some after evaluations to try to figure out what was happening. And then the other thing in terms of low utilization is like people who are actually attending. We've targeted, for example, the Latino community multiple times, at least with our objectives, but then finding that we can't find the partners. There's data to determine that need, but it's just still that low. You can't make be successful in it. even though we've determined that need, we know we would like to do that. That partnership's been harder, and we'll talk about that in a minute. So thinking about one of the things that with my new contact with the fire department, they were talking about that there's this particular age restricted community, so older adult community that is a hot spot where they're going for their most visits for due to falls. And so when we're thinking about like who we're working with, and if this is data, so we have that data, and I don't want to share like more information about that, but we'll just leave it kind of at that. If we have that data, how does this shape who our target population might be? And by target population, I mean, who would we work with? Where would we go based on that? So how might that change our direction for where we're looking? And I'll just say, for me, when I heard that, my ears perked up because I was like, oh, this would be a good area to address, to try to think about that. So who might that be? That data, how might that help us know who we'd be serving? Thoughts on that?
I want to know what kind of falls they're having.
Okay.
In the home? Is it in the community?
Okay.
That makes a difference in how it is that I talk to them.
Okay.
The topic.
So that's leading into our risk factor, which we'll get there. So how they're falling, and maybe thinking, all right, like that might be, well, could I have access to that age restricted community? A lot of them are gated. Can I get in? Can anybody respond to me? Or will anybody respond to me? And currently, no, but I'm not stopping. So I'm working my connections to see if I can get in there to do something. I have a sideways connection because the PT that's on our coalition, she has done some work there. So like I'm going to tap that to see in terms, but because the EMS has identified this area, it's kind of drawn me to that, because this is a way that you can use data to sort of say, all right, well, then we have to get practical. Do I have people? And do I have the resources? Do I have all the sweet spot connection to be able to do that? So we need to know like what else is happening in that, and I'll pull up that, and I'm looking at time. So I'm going to go ahead and go to just make a point here that we can use stats to help us prioritize the group that we're working with. The location, the topic. So to the risk factors, one particular risk factor, you could just pick one. You could pick one group, like frequent fallers, repeat fallers, a certain older adult group, a certain location. You might be asked, because it's affordable housing, then maybe you go and look up the statistics around what is affordable housing, who's there, and things like that, and what are their common issues and that kind of thing to help inform you. You could use the statistics like that Liz was talking about to guide what topic you talk about. Maybe what's the most important thing. The hospital, for example, our partners, they guide sometimes because they have things they want to accomplish. So, okay, that we can work that in, being flexible in terms of that towards the need. So finding, again, that sweet spot between like who you've identified, what you bring to the table. And that prioritized problem means not just like what you initially came up with, but where we can go with what we have, and partners and resources and the group that we've identified. And it morphs and gets more specific. And I think that's really critical. And this just talks a little bit more about that. And some of the target populations that we've done in the past at the coalition. So it could be a broad one. For example, the screening ones that we do, the big expos, there are whoever's has any concern about falls. It could be just for repeat fallers. It could be for care partners of people who've fallen. It could be, like I mentioned, affordable housing or a particular age group. Certainly, the older you are, your increased risk for injury and death happens the older you get. So while we don't usually trot out those really grim statistics, they are in the back of our mind of when we're reaching, maybe we target the oldest group among us because they're most at risk in terms of that. And then I mentioned also targeting, for example, by a particular group that hasn't been accessing services. And typically, the Latino community, at least in our area, doesn't typically interact with, for example, Legacy Link. They have, so that's a gap in care that we had identified. So when we figure out our need and we figure out who we have at the table and what group we've got, that's that sweet spot. And then what risk factors to address? I like to be specific. So I feel like if we're going to do an education, can we get specific to meet the needs of that targeted group? Maybe you survey them ahead of time and see what they want. Just kind of based on, and you should see these actually mirror what Liz had said in terms of what you choose to address, as well as either the risk factors or the protective factors. It's really, I emphasize in the coalition of using what's out there already. So like using the steady stuff. We mentioned My Mobility. You could do a whole presentation just on My Mobility. And then it would be a route in to go in another time and do a just fall related, because that one you just hit it lightly. So it's like it's a soft sell, although it's also kind of a hard sell because nobody wants to talk about the fact that they can't drive anymore, which is one aspect of that community part of the My Mobility plan. That's a whole other thing. And then and Liz did a great job showing you both screening things as well as handouts that don't recreate the wheel. They'll tell you if you can use them, and they've already gone through the process of readability and having the right amount of information and that kind of stuff on them. But you can do your own, and it is important when you have your events to do your own. Like when we have an event, say up in the mountains, we get together and we figure out what resources are there for exercise. So like, where's the Y? Is there gyms? Whatever. What are there classes that are being offered either at the local hospital or at the senior centers there? What are being offered? When are they? And they go on we always make a handout that wherever we are, so that those things are easily accessed. And again, I would just say, start small and build your connections. Like do one thing well and build the connections from that. And I have down here, target your groups, which means get specific, know who you're talking to, whether it's the professionals or the caregivers or the older adults or the oldest older adults or people who've had multiple falls, and then tailor those communications and the programs to them so they're meaningful. Let the people talk. So I'm going to skip this one, and go back to the fire one because of Liz's thing. So the EMS, when I went and delved deeper there, what they found, what they were saying was that they were going to the same house several times in 1 week. So now when we think about who we're targeting, now it's not only just this age-restricted community, but now it's the frequent fallers, the ones that the repeat fallers that EMS is picking up multiple times a week out on the floor. And so what we decided to do was focus on they weren't giving them they're not giving them any information about connections. So giving them the EMS people a flyer to help to try to create some of those connections is like one starting point. And I don't know Jill, if we have time to ask people this last thing. Do we have a couple more minutes?
Yeah.
Okay. So when we think about frequent followers, just kind of tying stuff all together, what are the risk factors with frequent followers? And Liz mentioned this. So one thing is that the if you fall, you're more likely to fall again. And the more times you fall, the more likely you are to get injured. Um, you know, I mean, and so and then with frequent fallers, thinking about those factors that stack up. So one thing that that we might ask is the chronic disease, vision issues, you know, just sort of those basic risk factors. And then from an environmental standpoint, in I talking further with my contact, they were saying that many of these people have houses that are like sort of hoarder houses where there's not a lot of space to walk. Now, my experience with these folks is they're not going to give up their stuff. That is like not going to happen. But you can create safe paths within it. But that's not. I mean, like to expect them to clean out their house and it be minimalist is just not. You know, they'll never let you back in your house. So thinking about like asking those additional questions, like going a little deeper about, well, when you're there, what are you seeing? And have they gone to the doctors in between time? Are they talking to their provider? Trying to make a route for that to be easier, you know, are all things to think about. What do you guys think about who else should we bring to the table in this case? Besides me talking to the EMS guy so far, who else might be a good community partner?
This isn't specific to community, but kind of overlaps. You had a comment in the chat about how to reach and inform families and caregivers, specifically that younger generation. How do you start the conversation with those partners in terms of the care team?
Well, and they make a good additional community partner here with respect. So to Liz's point earlier, we definitely don't want to come in heavy-handed. You could have a separate, so there is an organization, now I'm going to get the name wrong, but it's for care partners for, it's for children with aging parents or something like that. I know our Legacy Link, I've spoken with them. So there's organizations like that, and they bring speakers in, and they can give that sort of sandwich generation is really needs support because it can be overwhelming when we're respecting people's agency in their homes and they're falling, and you know they're falling as your child, and what can you do? So you know, seeking out a presentation, if there's not one, you can you know, we can set one up. Like, you know, that's where you reach out to you can reach out like to the area agency on aging and say, hey, can we have a talk on this, for example, and then they'll reach out to somebody to find the person to do it. So I think that would be a great idea. It's tough, definitely.
Jill mentioned ACAP, the Adult Children of Aging Parents.
Yeah, that's it.
Yeah, that one.
ACAP.
Deborah has a great comment in the chat talking about SR and Meta on risk factors for recurrent falls. They published something on that. What they found was that balance and mobility, cognition and mood, sensory and neuromuscular and medication risk factors resulted in up to 51% increase relative risk of in terms of relative risk for falls. Yeah, those are the usual suspects.
Well, and one thing in one easy way is to make sure that care partners are working with the person that's at risk for falls and the primary care physician or the pharmacist to review those meds. That's an easy lot, not a stressful kind of thing. I'm not trying to change my house or you know, say that you can't live here anymore kind of conversation, but that we can have a conversation around maybe a meds is causing you. And often people don't want to challenge their doctors. They don't want to say that this med, I'm dizzy with this med, because they figure the doctor gave it to them. And so then I must need to take it. And I think that it's critical to say, no, that's not working for me because it's making me dizzy and that kind of thing. Um, yeah. And I think that, letting maybe doing like Tom, to your question about the younger folks too, maybe there's just leaving a flyer around that is tailored to is somebody at your family has somebody in your family fallen, had an injury from fall, like to get their attention, and then talk what that is, but make it from like the state or something that's not like going to be, yes, have this device that pay money for or something, but from a reputable person to source in terms of that as a resource. Looking through the rest of these. ACAPS, it seems amazing. I presented there just once, but we have some faculty that go there multiple times, and it's a really neat support for folks too. Okay. Well, I think we'll stop there for the time so y'all can close up, right? Sorry.
This was perfect. Thank you so much, both Kay and Liz. Your comments and feedback were amazing. So were your presentations. I thought it was a really good discussion, and Kay, you gave a lot of really great guidance on how to build partnerships and use those risk and protective factors to kind of build the resources in community that are needed for those locations. And I thought your examples really highlighted how you can do this and make those connections and what some of those challenges are on the ground. So thank you for that. I am dropping into the chat a very brief evaluation survey. If people could fill that out prior to disconnecting, I would really appreciate it. We do use all of the evaluation results immediately to kind of help guide and inform how we do this in the future. So definitely appreciate the time that you take to fill that out. And for our next sessions, if you enjoyed this case-based format, we are looking for people in the future that might be willing to present. So if you have data questions or challenges that you've experienced in your programs, we are looking for you to kind of just come and chat through how you've been able to approach those problems and get guidance from the other people that are working in Georgia on how they might approach those problems, because we are here to learn from each other and to grow in community as to how we can work on falls prevention together. With that, thank you so much for your time. Thank you, everyone. And please follow up and let us know if we have questions. We will share this recording afterwards, and we will post it for those that were not able to attend.
Happy Friday.